So we saw all those problems and realized right away, trying to implement this software platform, a lot of these psychiatrists didn't even have a computer in their treatment room. So it's the implementation, we would have had to include a Mac in the installation fee. So it just wasn't really realistic.
Were you surprised by it?
Yeah, shocked. I didn't know mental health care was that, the state of it today. I didn't know.
Hello, everyone, and welcome to the Health Technology Podcast. My name is Christine Winoto, and I'm the director of the UCSF Rosamond Institute at the University of California, San Francisco. Today, we're talking to Matt Milford, co-founder of Foresight Mental Health. You'll be excited to hear what Matt is doing with his young company. He's got quite an incredible story. Matt was a Berkeley undergraduate in 2016, and that summer, he was studying abroad in France. He was in Nice on the Mediterranean coast on Bastille Day, July 14. A terrorist drove a truck through the crowd on the promenade, killing 86 people and injuring hundreds. Matt was there with friends, and one of whom died, and some of whom were physically injured. But after they returned to Berkeley, it became clear that many of them were also suffering from mental troubles in the aftermath of the attack. Matt looked for mental health support from the Berkeley Student Health Center. He found a tremendous need among students in general. It was clear that this need was overwhelming the campus system. And he found the wider healthcare system in America was awkward and expensive, and failing to help people who need it most. So he dropped out of Berkeley to found a startup that became Foresight Mental Health, which at the time of this recording is operating 7 centers in the Bay Area. Foresight matches patients with psychiatrists and therapists at very low cost. Foresight's goal is to use data to improve accuracy of diagnosis and treatment. And as they grow, their clean, highly structured data set is only going to lead to ever better outcomes. And I hope you enjoy our talk. If you like what you hear today, please subscribe to our podcast on iTunes. Well, welcome, Matt. Thanks for joining me today at UCSF Mission Bay here. And I thought when we first chat a while ago, you came to us about getting help and resources when you started this company, Genetic Foresight, and now the company is called the Foresight. But maybe we can take the listener back to from the start. You were an undergraduate in Berkeley when you started the company. So maybe you can go from there. And how do you get this idea about I want to start a company?
Yeah, great question. So you're right. I did start in Berkeley. I was actually a sophomore at the time, going into sophomore year. So around 2017. And at the time, I actually studied abroad in France over the summer. And there was a pretty big terrorist attack while I was there. And it ended up killing about 80 people.
Which terrorist attack? Which one is
in Nice, in France.
Oh, okay. Yeah.
There's a pretty large truck that came along on Bastille Day. Mm-hmm. And a number of my friends were down there and were influenced physically and mentally from that. So coming back to Berkeley and seeing a lot of them seeking therapy and psychiatry with expressing PTSD and depression and anxiety symptoms as a result. Seeing the lack of access to care, affordability, and the quality of care once they got in. I mean, we're talking about some of my friends were waiting about 3 months to even see someone for treatment.
You mean this is more on the mental health?
Right. So seeing that, and then if they got in, it was $500 out of pocket or even $1,000 an hour, and you're coming back every week too. So seeing that, I guess I was really interested in coming up with a better way to do mental health care simply. And my partner and I, Doug, started with the idea of a software platform to inform treatments, inform treatment decisions based on genetic profiles and non-genetic factors to give to psychiatrists. The goal eventually was to make a more scalable model where you would need less and less human interaction, or at least less psychiatrists, more general practitioners.
Can you help me understand about why genetic profiling can help?
Yeah, good question. Yeah, so genetic profiles can actually influence the prescription decision because in your genetic code, there's genetic sequences that code for enzymes that break down the medications and also the actual receptors that a lot of drugs bind to. So you can have pharmacodynamic or pharmacokinetic genetic mutations where maybe you don't have enough enzyme to actually break down a medication, so you should give less of the medication, a lower dose as a prescriber.
So you come up with that technology with the idea to improve the efficiency for many people with a mental health issue so that it can cut down their wait time? Or is it more like once they see the psychiatrist, then the psychiatrist can provide them the right dosage?
Ideally, both, right? So in mental health care, a big problem is, so it's not only the right dose, but also the right medication. A big problem in mental health care, especially depression treatment, is these patients will go through cycles of antidepressants before they find the right one. So often it'll take about 6 weeks for an antidepressant to actually take effect. So you don't even know if it's working for 4 to 6 weeks. You come back, let's say it's not, on average 50% of the time, the first one given doesn't work. Mm-hmm. So you're coming back and going through this cycle over and over again where you're getting these medications that aren't working. So ideally, if you could come up with a software platform to improve the efficacy of the first treatment, so you're getting a higher percent of success cases, then right away you have more availability because that patient's not coming back, taking up more of the psychiatrist's time. So ideally shortening that wait time, but also improving the matching to patients for treatment.
Okay, so maybe I can segue a little bit to go back to your experience when you and many of your friends were in the middle of this terrorist attack, and how many of you were there? And
yeah, good question.
Did everybody come back safely?
So there were about 80 of us studying abroad, mm-hmm. and I would say over half, if not 3/4, were down there on that kind of platform, boardwalk. Unfortunately, a good friend of mine was killed down there, and a lot of my other friends were hit by the truck, but thankfully mm-hmm. did not. So seeing that, obviously there's physical turmoil, but emotional, I think, is a huge part of it.
Sorry to hear that. So when you came back, along with many of your friends, you just went back to school. Did they provide some, I don't know, whether the embassy is supposed to provide some sort of support, or they kind of, you're on your own, buddy?
Yeah, so UC Berkeley has a great CAPS center, like through Tang. They have something called CAPS, Counseling and Psychological Services, as do many universities. And they're doing a great job for what they have, the budget, the resources. The problem is there's this massive demand for mental health care they can't sustain, mm-hmm. And it's growing. So in the last 3 years alone, there's been a 47% increase in depression diagnoses among students, a 30% increase among students seeking counseling services. So it's really difficult for the universities to keep up. And across the nation, you're seeing this big problem where these universities aren't able to sustain and support the student population for mental health services.
Do you think is it because more people seek out that help compared to in the past?
Yeah, it's a good question. So the root cause, there's a number of different theories. One certainly is destigmatization. People are more willing to go and get help. On top of that, a lot of people argue social media might be influential in depression or anxiety incidences, but there's not a whole lot of randomized controlled trials or anything to show that. So it's going to be interesting to see how it continues to trend, but there are a lot of people who believe that technology is playing some kind of factor. So mm-hmm. I would believe that it will continue to trend upward.
So going back to how did you and your co-founder Doug saying let's do this genetic, why you picked that route to solve the problem that you saw?
Yeah, good question. We actually played with a few different ideas. This was one of many in that area. Primarily, we were interested in applying technology to improve healthcare. That was something we felt was meaningful and worth spending time on. We ended up finding this field of pharmacogenetics actually through a couple of conversations with lab professors at Berkeley and professors there. And we were pretty fascinated by the idea. I mean, it sounds fantastic being able to match based on genetic code what the right medication is, because it's a big problem in healthcare. I didn't even dive into all the problems with mismatching medications, but outside of lack of efficacy, there's also adverse drug reactions, which are, according to the FDA, a pretty big cause of death. It's killing about 100,000 people a year, 2 million hospitalizations, so it's a big problem.
Yeah. So, and then at what point that you decided that you're changing from genetic foresight to foresight? Maybe for many of the listeners, maybe you can tell us, like, what does genetic foresight did?
Yeah. So genetic foresight created a software platform that integrated patients' non-genetic data, like medical and family history, symptoms, and a number of other things. The genetics were then incorporated through a pharmacogenetic test, and we designed a software system that could amalgamate that data and provide clinical decision support around what medication to select. So if you're prescribing for depression, as a psychiatrist, you have about 30 different options to pick from. It's very difficult to choose between the different ones because they're similar a lot of the time, and there's a lot of data on each one individually that they might not have time to go through. So although they know a lot of it from training, we were able to create a software with a large database on the back end that could quickly go through in real time and find what the optimal treatments might be with reasoning. So that was what genetic foresight did, and we raised a bit of money to pursue that. We're able to get a bit of traction. We got about, I think, 30 to 50 psychiatrists using it. But the monetization was pretty difficult. It was paid through insurance, the genetic testing. And the reimbursement was pretty shoddy. It went kind of fluctuated. A lot of medical devices and lab tests have that problem. So we had the option to continue and decide if we wanted to, bet on insurance companies eventually reimbursing it, which they would eventually. It's just, insurers move really slow.
Right. But you did manage to get some funding that prove that there's investor who believe that this is
absolutely
a need.
Yeah, I mean, it's a really exciting idea, and there's definitely a vision there that I'm sure will, there are certainly going to be companies who succeed at that.
Yeah, I remember when I first talked to you, I think you were really successful in gathering the right people, the right advisor. Mm-hmm. I don't know if you can share with some of the listeners who your advisors are.
Yeah, At the time, we were working with a number of pretty well-renowned psychiatrists in the area, in the Bay Area. One of them ended up being our medical director, actually, now. And then a number of other people in research. And then, a number of investors. I don't know how many of them would want to be named publicly. Okay. But, Rob Ness's syndicate was one of the larger ones.
Mm-hmm. So you realized that there's an uphill battle trying to get insurance, and then that kind of caused you to pivot to do something on the foresight side and then drop the name genetic foresight, become foresight. Can you tell us what is foresight question. And how is it different from genetic foresight? Yeah,
so let me back up. So through genetic foresight, we did about 100 customer development sessions where we essentially went into a psychiatrist office, met with them, interviewed them, 100 different ones. So we got a really good feel for the industry. We got to see firsthand what mental health care looked like today. Going into a lot of them were old recliner settings, library settings, really dusty, and almost none of them took insurance. So in the U.S., it's about 60% don't take insurance, roughly.
This is more like a private practice therapist instead of psychiatrist.
Yeah. So, and then on top of that, 55% are solo. So you got a lot of these disparate offices who don't take insurance. So there's lack of coordination of care, lack of affordability. And then on top of that, when we go there, they'd say, oh, yeah, I don't need to take insurance because there's so many patients who are calling my office every day.
And they're willing to pay cash.
Exactly. It's just supply and demand. So And then the last problem there, lack of affordability. So we saw all those problems and realized right away, trying to implement this software platform, a lot of these psychiatrists didn't even have a computer in their treatment room. So it's the implementation, we would have had to include a Mac in the installation fee. So it just wasn't really realistic.
Were you surprised by it?
Yeah, shocked. I didn't know mental health care was that, the state of it today. I didn't know. And so we uncovered that and all these problems, lack of incentive to improve things or innovate, deploy any technologies, or lack of possibility to even deploy them. And we really just wanted to start from scratch and reinvent the whole system. So that's what we did. We started in Berkeley with our first clinic, actually not targeting university students in any way. We didn't really know that was the biggest demand. So we got fortunate with that.
Do you work with the campus, or just happen that you're close to campus that you attract a lot of the students?
Yeah, good question. So we work directly with the campus, and we see a lot of students, and that's pretty much our strategy, is working with these different university campuses as we expand. But yeah, backing up. So we wanted to reinvent mental health care, the experience, ideally destigmatizing mental health care, and then the whole treatment experience.
So can you go over, as a patient walking in, what is that journey like when they interact with Foresight?
Yeah, good question. So you call, you make an appointment, you talk to a real person right away. That's above the industry standard, very low bar. And you're able to get in within, a timely manner, whereas the industry average is about 3 months.
What make your organization can do that compared to what's out there?
We're very good at recruiting, so we bring on a lot of clinicians. So the exact numbers, there's a lot of clinicians who are interested in working at Foresight. So we're seeing an overwhelming demand to work here, and then we can bring them on and see patients.
What is your value proposition that can, attract those clinicians to be working at your...
Yeah, good question. I guess so. There's 3 paths. They can work in a private practice, they can work in a clinic, or they could work at Foresight. So in a private practice, you have to do all the billing, all the dealing with payment collection or insurance if you're doing that, all the marketing, dealing with the lease or the office space, the scheduling new patients. There's a lot of providers who don't want to do any of that. They just want to see patients. So that's kind of a compelling reason between there and Foresight. And then looking at Foresight versus a clinic, the vision is a lot more exciting. So you can go and work at a clinic and treat patients, or you can work on really changing an industry that needs help.
So do you still have that technology to
Yes,
support?
absolutely. So we've deployed the precision medicine software in our clinical setting among a number of digital health modules that we've developed. And then we have our own electronic health record platform.
Can you tell us more about the digital module that you have, and how is that impacting the clinician and the patient?
Yeah, so we have a number of digital health modules. The overall goal of all of them is to improve the accuracy of diagnosis, and then the optimal treatment selection, medications, therapy modality, nutritional supplements, meditation, mindfulness, sleep, physical activity. There's all kinds of treatments. So we're doing that through data. I can't go into a whole lot of detail there, but the goal is to come up with more accurate diagnosing and better treatment selection.
And I know before you shifted to Foresight, when you were at Genetic Foresight, you have gathered a lot of data. And being in a technology in the space where there's a lot of data, there's always, a lot of companies face the challenge. They have all the algorithm, they need the data. How do you solve that problem?
Good question. Well, we're very fortunate in that we have clinics producing a lot of data. So a lot of companies, as you're alluding to, run into the chicken and egg problem where they don't have a product until they have sufficient data to train an algorithm. We have clinics that, they're a business model. They're a successful business model and by itself could work. But they also produce a lot of data that can train models.
So before you have your own site, you work with different clinic who has produced a lot of data. Is that it, or that's
there are
not it?
different types of algorithms. So there's empirical algorithms, and then more learning, like machine learning or AI-based algorithms. So right now we have a mix, but the goal would be to transition more and more towards learning-based algorithms as we collect more data.
So one of the things that I learned within the space of patients' records or physician observation, that can be really messy data. And how do you overcome that challenge?
Yeah, I mean, the biggest strategic advantage we have there is we have our own electronic health record. So all the data we want to collect is highly structured and standardized or normalized. So we actually have a really clean data set. And then we have outcome data that's also quantitative, complete, and structured.
This podcast is sponsored by Brown Ratnick's Global Life Sciences Group, a team of legal professionals that helps life science companies, lenders, and investors around the world turn good science into good business. Learn more at brownratnick.com. So how big is your clinic now, and where is it?
Clinics?
Yeah.
We have 7 across the Bay Area. So we're expanding quickly, though. So a few more planned in January. And mostly around the Bay Area right now.
And each clinic, how big? I mean, it's an outpatient clinic. And how does it work? How many patients can you see in a day? I would know what that is.
Yeah, so each clinic's, roughly 2,000 square feet, has about 8 providers. Just depends on the mix between psychiatry and therapy, what the capacity is for number of visits. So it kind of just depends.
And does that mean the patient, can they use their insurance, or is it also something that they have to pay cash?
Yeah, a critical part of Foresight is it's all insurance driven. We want it to be extremely affordable. Most patients don't pay anything to come into Foresight. So it's very cheap, $0 to $15 copay.
Okay, so is that because you have the clinic? That's why you can do this
we have group contracts with all the major insurance companies.
Okay. And you mentioned earlier also the fact that you team up with university. How does that work?
Yeah, it depends on the university. So in general, we form a partnership with the CAP Center. And we're able to work with them pretty closely to improve care for their students and accessibility.
Can you say what CAP Center is?
Counseling and Psychological Services Center. But yeah, we are working on some more deeper partnerships on the data level there.
And so in addition to what they have on campus, they start referring patients to you?
Exactly. Yeah, so like I said before, they don't have sufficient provider base or supply to actually support those groups.
So when you change from genetic foresight to Foresight, those 7 clinics that you have probably require some capital investment. And so how does that work? It's so different from when you first started the idea of doing something technology where you just do things in your computer and all of a sudden you're on brick and mortar.
Yeah, so the first clinic we were able to use with the first round funding that we raised with the software model. We essentially told our current investors that model wasn't working and we were going to pivot. A lot of them told us we were crazy, but we did it and we're very successful. And the recent round, we closed our seed round of about 1.3 million that enabled us to set up the next 6.
Okay.
We still have some more to
And I think it's also because you got some contract from the insurance that helps pay
exactly
the operation.
Yeah, a key here between us and a normal pure tech company or deep tech or med tech or digital health is we actually generate revenue and cash flow before actually needing the money. So whereas a deep tech or someone going through any kind of regulatory process, they have a long time before they generate any revenue to cover any overhead. So not all of that seed round is deployed as a result of that.
So do you still require some FDA approval for your technology, or has that been approved?
Yeah, we work through clinical decision support software guidelines. So there's a separate kind of regulatory body there that the FDA oversees.
And so, how is it I mean, you've done both, right? The technology and then running a brick and mortar. What are the skills that you did not know then and that you have to quickly learn?
That's a good question. I would say there are a million skills. So, I mean, when we're...
Give me 4.
Negotiation is a big one. So I think negotiation is critical for, working with insurance companies, for example.
Can you give me an example?
Yeah, every insurer will negotiate rates that they pay you, and those rates are what you basically operate with. So those are pretty important to set the price point, right? Whereas most companies have the luxury of setting how much they want consumers to pay them. We don't. It's driven by insurance. Mm-hmm. So that's one. Sales is another. I didn't have any sales experience, but when we were doing sales before, in more of a genetic foresight, I learned a lot about, the sales funnel, sales engineering, optimizing each level. It was definitely a really interesting experience and very different from my degree in engineering.
Right, that's very, very different. And oftentimes what I learned with working with insurance is it's hard to find, because I think when you negotiate pricing and everything, mm-hmm. knowing what the data, mm-hmm. that would help inform your Absolutely. Negotiation. How do you do that?
Yeah, we're fortunate where we have quite a high volume of patients where we can say, here's our outcomes. So we can say, real world outcomes too. So not a clinical trial necessarily, but real world outcomes is really where the industry is heading in healthcare.
This is when you're still at with the genetic foresight patient
no,
or
foresight
yeah. Already. Okay. But then so there's a certain period in the beginning where you didn't have any insurance
exactly yes.
Contract,
Correct.
Yet you're still seeing patient, and at that point, mm-hmm. your model will be more like a cash-based instead of reimbursement.
Back then? Mm-hmm. We had individual contracts, which are harder to obtain or easier to obtain, but they're really slow. So we had a limited growth period where we couldn't really do much when we didn't have the group insurance contracts.
What do you mean by individual contract versus group contract?
So as an insurance company, essentially you have a provider network that you can refer your, let's say, Anthem Blue Cross members to. And you have physicians, specialists, and all kinds of things. What we could do is, or as an insurance company, you can either contract with 100 individual providers, let's say primary care doctors in San Francisco, or you can contract with groups like UCSF. Mm-hmm. The advantage of contracting with groups for them is there's a lot less administrative overhead where they only have to manage one point of contact versus 100.
Mm-hmm. Okay.
So in the beginning it was individual and now it's group.
Looking back, I mean, you grew in a really short time, and it's amazing. And I know when you sent me the update, every time I was like, wow. Every time I was like, wow. And that's because thinking back when you first started, and of course, the fact that you pivot, what helped you make that decision? Do you surround yourself with the right advisor? How do you decide that's the idea that you should follow?
Yeah, I guess, so we'd been working on this software model in genetic foresight for about a year, and we're getting some traction. It was a lot slower growth than we'd hoped, as most startups experience. But we learned so much about the market through that we had zero doubt in our mind that if we started going after a more of a clinic model, we'd have a lot of success in that. It was a very tough decision. There's a lot of trade-offs in software models versus brick and mortar. As we grow, though, we are deploying quite a lot of technology and collecting a lot of data, and those have different paths that we can pursue in the future.
Mm-hmm. So when you came back from Europe, and then you probably went back to Berkeley for a year and started the company, and before you finished your undergraduate, your parent must be like, what? Or not really. It's like, you went through a hard life, do whatever you want.
Yeah, my mom's a doctor and my dad's a PhD, so they were pretty interested in me staying in undergrad. But yeah, both my partner and I took off after our sophomore year to work on Foresight full-time. And yeah, I'm very glad we did, because I think at the time we only had a year left on our degree, so we could have finished in 3 years. But
why rush it?
Yeah, so one way to do it would be to take off a year to pursue this idea that we had. And, we had a lot of conviction and we were interested.
So you kind of said, let's try it for a year, and then it turned out to take off. Then it's like, okay, then I'm not going back to school.
We said, we were pretty committed at the time to doing it. And worst case, it fails in a year and we go back, which, is kind of a safety net, which isn't always a good thing in entrepreneurship. But after the year had elapsed, we ended up having to pivot. So clearly we didn't go back.
And now you have the 7th clinic. It's kind of...
Things are going really well right now.
Right. So it'll be hard to go back to the classroom again.
It just depends. I think there are certainly things I want to learn still that a classroom setting would be optimal for. But it just depends.
Yeah. One of the things that being in the healthcare is you see that all the time in the tech world, where people start a company before their senior year or their junior year. You don't see that happen much at the healthcare side of things. Do you feel that when you started this effort, do you feel like there's a lot of pushback from investors, network, to see like, go back to school, young man, kind of thing?
Yeah, good question. So I think the reason behind that is healthcare is very slow moving and a lot of it's relationship driven, especially with these insurance companies, which a lot of the time drives, the market and what's adopted and what's not. We were fortunate that we had quite a great ecosystem at UC Berkeley and, a great list of connections that we developed through accelerators and different incubator programs and our network that we didn't run into a ton of pushback on, you're a young founder, you don't have any healthcare experience, how are you going to do this sort of thing? I'm sure that was in the back of their heads, but wasn't outright said.
So I'm glad that that you pushed through. I think that's great. Well, thank you so much.
Yeah.
It's been so nice to hear your story.
Yeah, thank you so much for having me again. I appreciate it.
Thank you for listening today, and don't forget to subscribe to our podcast on iTunes.